Hi, everybody. All right, we're going to get started on Section 2, Classification, Diagnosis of Diabetes. This section is super important to pay attention to. This is how we diagnose diabetes, type 1, type 2, and then we'll talk about the other more uncommon types of diabetes. So we have type 1, type 2, gestational, and then there's other types of diabetes as mentioned down here, which we will talk about. But one thing to remember is go back to this pathophysiology. I am going to post a video on insulin resistance and type 2, but type 1 diabetes, it's more or less, it's an autoimmune disease, it's hereditary, usually in first degree relatives, and they have complete beta cell destruction. And remember, that is in the pancreas. So beta cell destruction is responsible for insulin secretion. So these people need insulin. Type 2 diabetes is different. It's insulin resistant. So we'll get more into that. But again, how do you diagnose these is what we're going to learn about, as well as the different types. And I know that we diagnose with the A1C test now, which has been wonderful, but we always have to remember too, there are some variants, and not to forget about that, because we have to remember what the A1C really is. Remember, it's the amount of hemoglobin sitting, or amount of glucose sitting on our hemoglobin. And remember, our red blood cells are recycled every 90 days, or hemoglobin's on the red blood cells. And so people with issues such as sickle cell disease, and even think people on dialysis, or if they've had transfusions or blood loss, if they're on erythropoietin therapy, and usually that's with chronic kidney disease, that A1C can be altered. So you have to always take a look at what that plasma glucose level is versus the A1C. And the other thing to remember with an A1C, it's an average. It doesn't give peaks and it doesn't give the lows either. And it's a great test, and it gives us a guide to see where the patient's going, or if they're stable. But just keep that in the back of your mind, because I think we take A1C for granted and think, okay, well, they're 5.7, they're fine. They're just borderline, but we need to take it more seriously with symptoms and stuff too. All right, so this is staging of type 1 diabetes. So remember, it's complete destruction of the beta cell, but there are stages of it. So when someone is first diagnosed, they might not have complete destruction of all the beta cells yet. But over time, it will eventually get worse, and usually their insulin needs will end up going up. Unless they follow a really good diet, with less carbohydrates and stuff. But most of these people just think, like, in the beginning, they might not require as much insulin as when they get to stage 3. But stage 1, let's just say you have a first degree relative with diabetes, you can go ahead and get anti-autobody, oh my gosh, I can't talk today, autoantibody testing done. And I'm going to show you in a minute the specific autoantibodies and lab tests that can be drawn. Is this done in primary care? I would say basic ones, but then there are ones that get to be a little bit more expensive, and that's when you probably would send to endocrinology for that if you suspect that. But there's no reason why we can't get an insulin level and a C-peptide level just to see if they're making insulin. So stage 1, you don't have any symptoms yet, and stage 2, you start having some abnormal glucose, but you're really not symptomatic yet, and that's when you're going to get that fasting plasma glucose 2-hour, and you can also get an A1C. Just remember, an A1C is not the best way to diagnose type 1 diabetes, though. Then when you get to stage 3, you're having clinical symptoms, and all of a sudden they have this spike in glucose and are symptomatic. And unfortunately, many times we end up diagnosing type 1 diabetes because they end up in diabetic ketoacidosis in the hospital with the blood sugar of over 800. So this is a general criteria for the diagnosis of diabetes. I can't talk today. I'm fighting bronchitis too, so sorry about that. All right, so your plasma glucose fasting should be greater than 126, and you should be fasting for at least 8 hours. I say 12 hours is even better. Or you can get a 2-hour plasma glucose greater than 200 during the oral glucose tolerance test. So this is the oral glucose tolerance test. It's really only used for pregnant women, and not so much if you're just diagnosing diabetes. It's inconvenient. It's just not as much of the standard of care as it used to be, but it is an option. Also, the A1C we can use now as a diagnostic tool for diagnosing diabetes, and it's greater than 6.5 would be diagnostic of diabetes. Or in a patient with classic symptoms and they have a random plasma glucose of greater than 200. So these are the patients that they come in your office and they're like, I have really blurred vision, I have polyuria, polydipsia, you know, they have multiple symptoms, and then you're like, let's just check your blood glucose, and it's like 340. That's happened many times in my practice. So what do I do with that? Well, I end up suspecting that they have diagnosis or they have diabetes. You can technically put a diagnosis of diabetes in their chart. At that point, what I usually do is put elevated glucose. I'll get an A1C. I'll have them come back in a couple of days. We'll go through the labs. I also get like a lipid panel, complete metabolic panel. I get more labs if they have not had those done. But technically, yes, you can diagnose that. And another thing to remember, if your patient comes in for follow-up and they have a fasting glucose on their complete metabolic panel or basic metabolic panel greater than 126 or equal to 126, I would repeat the test. So that would be the best recommendation to do for diagnosing diabetes. All right, so back to type 1 diabetes. Your plasma glucose rather than your A1C, which I mentioned before, is the best way to diagnose the acute onset. You will get an A1C, and you know it's probably going to be high. Screening for type 1 diabetes risk, though, with a panel of autoantibodies is recommended only in the setting of a research trial or in a first-degree family member with a proband with type 1 diabetes. So really, there's no screening recommendation unless you have a first-degree relative with type 1 diabetes. And as far as the family member having a proband of a proband, like they had genetic testing, I would still get the genetic testing done or would get more autoantibodies testing. So if you have a persistence of 2 or more autoantibodies, it predicts clinical diabetes, and you can use that to do an intervention, meaning that you can go further saying, are we in a pre-type 1 diabetes, a stage 1 or a stage 2 process of that. I'm going to escape out here because I do want to show you the lab testing. All right, and I also am putting this in a Word document for you guys to see. All right, so C-peptide level is the most common one that's done, and C-peptide mirrors insulin level. So if you have low C-peptide, you can say that your insulin level is low. So you're not secreting the insulin. So you're eating the food, and insulin, not enough can secrete to bring that the sugars that you had just eaten down. And remember, sugars are also carbohydrates that break down into sugar. So it could be pasta, grains, even whole grains. I can do that, which we'll talk about that later. There's insulin autoantibodies, and that looks for antibodies. Are there any antibodies targeting the insulin? And as well as insulinoma associated to autoantibodies. And there's zinc transporter, islet cell, and the GADA or anti-GAD. Now, again, these are very expensive tests. Not as much, the C-peptide's not as expensive, but I've drawn C-peptides quite a bit, as well as insulin autoantibodies. If those are abnormal, I will send to endocrinology. But again, it just depends on your practice. What if you work in a rural area? What if you have a collaborating that, you know, really has specialized in that, and he's, you know, hey, let's treat this way. or you become comfortable in doing that, I say go ahead. We are perfectly capable of doing that. And, once you have those, then you would send to endocrinology for management of type 1 diabetes. I always have my type 1s in endocrinology. And that's very common. All right, so I'm going to go back to this and go back. Okay, so now let's talk about pre-diabetes and type 2 diabetes. Remember, this is a little bit different because these people have more insulin resistance problem. So there's risk factors, which on the next slide, I'll show you what the risk factors are. But you should test for, do a fasting blood glucose in patients, or you can get an A1C or in anybody who's overweight or obese. So if your BMI is greater or equal to 25 or greater or equal in Asian Americans, and who have one or more additional risk factors, which is on the next slide. But in general, all people you should test with at least a fasting blood glucose greater than at 45 years old and greater. And then you should test them every 3 years. Now, here's the criteria. So if you're obese, you look for any of these risk factors if you have one of them. And usually people will fit that criteria pretty easily. A lot of people have hypertension or a history of a low HDL. So this brings up a very important issue with metabolic syndrome. And I had mentioned in my other slides, if you do anything, let's just really try to focus on prevention in our primary care setting, because we don't want people to become diabetic. We have to be more aggressive. You'll see physicians out there, and I'm not trying to pick on them because there's awesome physicians, but there are some that just watch the fasting blood sugar. And granted, yes, a lot of patients are resistant to starting metformin and stuff, but I have seen some physicians just not tell the patients that they have a fasting blood glucose in the borderline range, and they just keep getting their labs drawn because maybe they have high blood pressure and high cholesterol and are obese. Well, guess what? That person has metabolic syndrome. And again, when I think of metabolic syndrome or prediabetes, you have a carbohydrate intolerance. You have a metabolic issue. And so these people are eventually going to be diagnosed with diabetes. And as we know, once you're diagnosed with diabetes, your risk factors for heart attack, stroke go up at least fourfold. Whoops. Okay, let me get back to that. Okay. All right. So, and the other thing I want to mention is gestational diabetes. We have to take that seriously too, because there's a huge increased risk of them becoming diabetic post having gestational diabetes, including myself. I was gestational diabetic, and with my third child at age 30, although prior to that, I had risk factors. I've had high triglycerides, low HDL, starting in my late 20s. It's very genetic. And because my BMI at that time was like probably 19, I've always been more of a thinner person. And so then I became gestational diabetic, and, they warned me, you have to watch it. Well, I didn't. And I ended up with borderline diabetes for about 5 or 6 years on medications for my triglycerides. And then what happened? I became diabetic. I was diagnosed a little over a year ago now. So since that time, I have lost more weight just because I've had to stop carbohydrates, and been on metformin, although I'm off it now because of lifestyle changes. So not a majority of the population is obese, but not everybody is. That's why metabolic syndrome is important to look at, because I was not overweight, but yet I had low HDL, high triglycerides, and I had a borderline fasting glucose. So you have 3 out of the 5 criteria for metabolic syndrome. Please look up metabolic syndrome and see what the criteria are and have that on you. Waist circumference, low HDL, high triglycerides, borderline fasting blood sugar or elevated blood sugar in general, and a waist circumference of greater than 35 in males and 40 in females. So if you meet 3 out of the 5, you just might as well say, you know what, you're pretty much diabetic and you have to treat them as such. Sorry to go on my soapbox, but it's just really important. All right, so again, for testing, you can do the A1C and the fasting blood sugar. I'm not going to go through this again because I talked about this on a slide before. And we also have to pay attention to children now because we are seeing much more obese children. We have to think about that. I know you guys, I think, cover pediatric stuff in your next course. So you'll talk about that. So I'm not going to go through this, but just know one key takeaway is that if, for example, I was gestational diabetic, so my son, who's now 18, he's at risk for diabetes as he, grows and becomes older. So it's not only the mother, it's the child that is at risk. This is an awesome tool, and you should have this in your office in every exam room. I think this comes in handy for my patients and me. This really helps to determine, it helps me to say, oh, let's look at metabolic syndrome symptoms. What do the labs show? Because again, I want to catch these people early. So you can get that on the diabetes.org, the SOC risk test. And then pre-diabetes, again, what we're trying to capture is between 100 and 125. We usually don't do oral glucose tolerance tests, although you can. And the A1C is between 5.7 and 6.4. You have to really monitor those. And again, you might see people, let's go back to this slide, you might see people with the fasting blood glucose of 106 every single time, but yet their A1C is 5.2. That's happened. Doesn't mean that the A1C, because that just tells me the average is still below 100. But morning time, they're starting to have this insulin resistance. Because remember, in the middle of the night between about 3 and 5 a.m., your body kind of wakes up and says, oh, I need to feed myself. So your liver excretes glucose into your bloodstream. And if you don't make enough insulin or have enough insulin to bring that down, hence high blood sugars in the morning. So there's something called a dawn phenomenon, which is really common on people with diabetes in general. There's a Somogyi effect where usually you go hypoglycemic in the middle of the night, but the dawn phenomenon is the opposite, where you have this secretion of glucose into your system, and then you wake up with this fasting blood glucose. Gestational diabetes, it's done in the second trimester, and that is where they do the oral glucose tolerance test. It's done between 24 and 28 weeks because you're in the second trimester, and that is when your body starts to secrete more glucose into the system due to all the hormonal changes. And so those who are pre-diabetic, or meaning insulin resistant, you're going to test abnormal, and that usually will happen around that time. So what does that tell me? That tells me that, say you weren't diabetic at all before, but now at 24 to 28 weeks, your body's unable to handle the sugar that's going in your system because of the insulin resistance. The insulin's not being able to get into the cell to get rid of that sugar. That tells me that you have probably a metabolic problem, and you are at risk for that as time goes on in your life. Oh, and as far as testing for that, they should also be tested afterwards, at least every 3 years. Lifelong screening. All right, and I'm not going to go through this, but you can read through this if you want. As far as testing on your certification exam, it does not get specific as far as, all right, what should your blood glucose be 2 hours post an oral glucose tolerance test? No, it's not going to be that. You just need to know what the glucose tolerance test is, how to diagnose diabetes, and when you're going to do the oral glucose tolerance test, and learn about gestational diabetes. All right, so now there's cystic fibrosis related to diabetes, and the pathophysiology, or just a brief summary of what that is remember cystic fibrosis, they have that sticky substance, and it also gets on the pancreas, and so it damages the pancreas, and so then the beta cells don't work, and a lot of these patients have to end up going on insulin. So these people should be monitored for that. Usually those people are in endocrinology and seeing specialists. All right, post-transplantation diabetes. So if you have a pancreectomy, you are at risk for that. Oral immunosuppressants are going to be the key, though. So it's not that you have to go out right away and say, oh, this person needs insulin. Again, these people are going to be in endocrinology. But immunosuppressive treatments does show really good outcome, and not necessarily need insulin, but everybody's different. Now, monogenic diabetes is a single allele, like it's a single band abnormality on your gene, and it's diagnosed within the first 6 months of life. And so it's one of those that you really don't have type 1 or type 2. It's called monogenic diabetes. And they don't have typical features. So like your autoantibodies are negative, you're not obese, no other metabolic features with a strong family history of diabetes. They usually have a stable mild fasting between 100 and 150 and a stable A1C between 5.6 and 7.6. But remember, these are early in life, or these are diagnosed within the first 6 months of life up to early adulthood. So all children diagnosed with diabetes, if you're less than 6 months old, should have immediate genetic testing. That just seems like a no-brainer. As you can see, it's a recommendation level A. And children and adults diagnosed in early adulthood should have genetic testing also. Now remember, level E means expert, like expert advice, and the consensus is in that. So there's a link down here, beyondtype1.org, and it explains more about monogenic diabetes. And that is it on this set.